Bonda sir. He will be speaking on beyond RCHOP in the management of NHL. So sir is associate professor in Homi Bhabha Cancer Hospital in Vizag in Department of Adult Hemato-Oncology. Sir, I am handing over the screen to you.
Thank you. Good morning, everyone. First of all, thank you, dear Akhil, and thank you, Professor Mishra and Varanasi Department of Medical Oncology for giving me this opportunity. In the next few minutes or so, I'd like to take you through um, the journey of what has happened or how we can actually improve the outcomes in DLBCL beyond RCHOP. So, I'll try to share my screen. Yeah, is this? I suppose the screen is visible to everybody.
Yes.
And yeah. So all of us know that DLBCL is the most common type of non-Hodgkin lymphoma, accounting for about 30 to 40% of the non-Hodgkin lymphoma cases, and most of us know that it is predominantly curative with a combined chemoimmunotherapeutic approach. That what I meant was R-CHOP. So if we actually take a large cohort of around, say, 500 odd patients, sustained remission or long-term cure is what we are expecting in around 60% of the patients. That is, in 60% of the patients, we have long-term cure. But the rates of relapse, they still account to around 30 to 40%, and refractory disease is seen in around 10% of the patients. So when you're actually using a uniform chemoimmunotherapeutic approach, this is the diversification in these response rates, or perhaps the chemosensitivity of the disease, and resulting in differential outcomes across the patient population itself is an indication that probably DLBCL is not perhaps a one-size-fits-all approach is not possible with DLBCL. And it also indicates or points towards an underlying heterogeneity, either in the patient population or the biology of the disease, which we need to identify at the beginning and perhaps tailor our approach or make a precision-based or a personalized approach for management. Now, how far are we successful in that is the quest for me today. So all of us have realized, I mean, for over a period of time, that DLBCL has a heterogeneous biology, and identification of clinical and molecular variants that contribute to this heterogeneity is what we have been so far successful. The measurement of the success, I leave it to you. What we have obtained a consensus is regarding to the identification of these high-risk subsets. Yes, all of us know that who do bad and who do worse, and of course, who do good. So there is a consensus, at least a uniformity in these, and all of us know that this particular patient is not going to do good. But what differential approaches or what different therapeutic approaches can we adapt to based on these risks is a controversial issue. So we have a consensus in identification of these high-risk subsets, but what to do them, it still remains controversial and it still remains blind. So today, trying to go beyond RCHOP, or where the story of RCHOP ends and how to take it forward or how to improve on RCHOP is something that I try to discuss in the next few slides, because all of us know that the benefit that rituximab has produced over and above CHOP is close to 15 to 20% across the various groups. And building something above that or improving some on that is something which is difficult. So here comes the role of actually identifying which particular subset of patients or which subset of disease population as such will benefit from this. So being a clinician, I would actually first of all take you to the cornerstone of prognostication of the patients of diffuse large B-cell lymphoma by using a time-honored, time-tested approach, that is the International Prognostic Index, that is the IPI. The original IPI, all of us know, I don't have to enumerate this. As you can see that the differentiation or prognostication of patients based on different groups into the low and the good and the high risk population is very clearly demarcated in the IPI. And this we have used for several years, and this we have been using various variants of these IPI have spawned over a period of time, but still this clinical prognostication of diffuse large B-cell lymphoma has stood the test of time, and we continue to use it today, till today. Of course, as you can see in this slide, that the high-risk population, whatever IPI or whatever prognostic index that you use, remains to do bad, whether you use your NCCN IPI or whether you use your the original IPI. So this helps us, the clinical prognostication helps us in actually identifying this particular population of high-risk group in the OPD, sorry, on a day-to-day basis. Now, integrating our molecular variables or molecular subsets into this clinical prognostication is something which is a dream come true. And for a clinician like me, where I can actually have a side-by-side integrated approach of using the clinical parameters as well as the molecular or genomic profiling, whatever you may call it, and then to come out with a prognostication or a personalized approach of managing my particular patient with DLBCL. So if this is one of the comparisons where people have tried to compare which would be a more robust or a more better comparator or prognosticator when compared to the IPI. So people have tried to put IPI, the RIPI and NCCN IPI, and this has been validated in several cohorts, large-scale cohorts, and it is claimed that NCCN IPI is a more robust prognostic index when compared to the IPI. But having said that, even the IPI also is a good enough or a time-tested prognostic index that we have been following. And currently, we shifted to NCCN IPI because of the recent validation from the Canadian and the DSNHL subsets or validation cohorts. So whatever said and done, this is the clinical prognostication which we have been very familiar with and which we have been using over the past few decades. And I suppose as clinicians, we continue to use it. Now, this is a table where I have tried to put together the various biomarkers we actually can use for prognosticating or even for predicting the response therapies in diffuse large B-cell lymphoma. A couple of them are considered as a standard of care. That is, your IPI is a standard of care. Then immune expression, sorry, the phenotypic expression of BCL2, MYC, and BCL6 by the immunohistochemistry is again a standard of care. And of course, the various target-specific IHCs, they are standard of care, but probably they are not, a prognostic. But definitely, they help us in identifying a therapeutic target when it comes to treating those patients. And what is important is the FISH for BCL2, MYC, and BCL6 abnormalities. Yes, it is considered as standard of care. It's an integral component of the diagnostic workup of a diffuse large B-cell lymphoma. Now, identification of this cell of origin by using various platforms like nanostring or LIMP2CX assays, these have also been considered as standard of care, though we do not do them regularly in the day-to-day clinical practice. Are they prognostic? Yes, they are. But do we have a therapeutic target for them? Perhaps not yet, or not really yet. So coming to when we actually see a patient of diffuse large B-cell lymphoma in the frontline setting, we have certain high-risk parameters, or we can define the high-risk parameters based on the molecular subtype, that is the germinal center type or non-germinal center type, specific genetic aberrations, when I mean the MYC and the BCL2 translocations or P53 mutations, and specific viral etiologies like EBV and HIV and HHV8, where these lymphomas, when are associated, they do bad when compared to their counterparts. And certain phenotypic distinctions where the overexpression of certain proteins like, again, MYC, BCL2, BCL6. So these are certain high-risk parameters which we look at in the frontline setting when we are treating a patient with DLBCL. And perhaps are the clinical parameters like the international IPI and other clinical parameters, and perhaps an unsurmountable factor where advanced age comes into play, and of course, the extranodal spread, that is CNS involvement. So today we'll try to analyze how and what can be done beyond R-CHOP, or what can we do beyond R-CHOP in actually trying to address these specific scenarios. So this is what my dream, or anybody, a clinician's dream would be, to actually tailor or personalize the treatment of DLBCL based on evidence, including both the clinical variables, as well as to undergo a comprehensive pathologic and genomic categorization, or the molecular classification, and perhaps result in identification of that particular high-risk patient who would do bad with the standard chemoimmunotherapy regimen, and select or enable us to select certain individualized treatment approaches for this particular population. And this remains to be a dream come true for most of us clinicians. I'll just take you back to the early 2000s, when the first ever publication on the identification or distinction of diffuse large B-cell lymphoma into the based on the cell of origin has come up using the complementary DNA microarray assays, where the expression of the genes in relation or in comparison to their normal lymphoid subsets was studied, and by using what is called as hierarchical system of division, people came up with the division or classification of diffuse large B-cell lymphoma based on the cell of origin into the germinal center type and the activated B-cell type, again based on the similarities of gene expression to the normal counterparts, that is the germinal center or an activated B-cell. Now we have come a long way in the past 2 decades from using the microarrays to RNA sequencing and perhaps the whole exome sequencing. I'm not going into the details or the molecular details of each and every one of these because of the time constraints. I just tried to put all those, the fancy cartoons which we see in nature and cell into a simple way of trying to identify. On the bottom of the cartoon, you can see what gene expression is, what gene expression separates the germinal center type and activated B-cell type. And above that, because all of us know that gene expression profiling is not available day to day or not available so common, people have come up with what is called as an immunohistochemistry based algorithms. And there are several algorithms again, and the one which we commonly use in our practice is Hans algorithm. And this is an indirect way of actually trying to assess what would be the gene expression profiling of these patients. And all of us know that the concordance rates are pretty good, and perhaps the identification of the non-GCB type is much, the sensitivity is much higher when compared to the GCB type by using any of these algorithms. So these are certain modern classifications where people have tried to do what is this whole exome sequencing, and they have tried to identify the molecular subtypes of diffuse large B-cell lymphoma. As you can see on the left-hand side of the slide, there is a genetic classification where people have divided DLBCL into 7 distinct subtypes. This is based on a platform called LymphGen. And so this actually divides the patient in the beginning. But having said that, or having studied about these genetic subtypes, in our day-to-day practice, do we essentially have an answer to each of these is something that we need to consider, because most of the times we know that this particular patient is going to be bad. We know that there is a specific therapeutic target, but translating or treating that or targeting that and translating it into a reasonably a good clinical outcome or a reasonably good survival benefit, perhaps that is where we are lacking. So we identified what the problem is, but in order to find a solution for that, we still are in our journey. So I would like, this is again a summary of all those, this is again a summary of all this, the novel classifications that we had for DLBCL. If you can see, I'll just take an example of the Harvard cohort. It is one of the largest cohorts, which was initially published for genomic classification of DLBCL, and they have actually identified certain clusters of the DLBCL subtypes. If you can see, the cluster 1 and the cluster 5 predominantly are the activated B cell type, whereas the cluster 3 and 4 are the germinal center type. They also found out that the cluster 2 is actually cell of origin independent. And if you can see that there we have what is predominantly the P53 aberrations and P53 dysfunction or biallelic inactivation of P53. Now, the prognostication or the prognostic impact of these is also well known, because all of us know that patients with germinal center, non-germinal center or activated B cell type, they do bad when compared to the germinal center type. And in akin to that, if you see the cluster 2, which is the cell of origin independent or unclassifiable, they have realized it's the risk or the progression-free survival for these patients is again bad when compared to the de novo germinal center type. So perhaps from cell of origin, we have actually moved on to an exomic classification or a genomic classification, where we can identify that apart from the GCB and the ABC type, perhaps there is something more that needs to be addressed. Similarly, if you also see that, you can see that in cluster 1, there is predominantly, along with MYC, there is BCL6 structural variations. And if you see cluster 3, which is predominantly a GCB type, you have BCL2 structural variants along with MYC. So probably when I talk about MYC and BCL2 or BCL6, the erstwhile definitions of double hit lymphoma or a high-grade B-cell lymphoma with MYC and BCL2 or BCL6 translocations comes into play. And we should realize that probably the group, the biological group of a double hit lymphoma is not in so homogeneity as it seems to be. Perhaps there is something more within the double hit lymphoma or high-grade B-cell lymphomas which actually express both a MYC, BCL2 and or BCL6. So with that, why are we worried, or why are we interested in actually understanding or studying the GCP and the non-GCP type of DLBCL is because of its therapeutic implications in targetable targets. So when we look at the targets here, all of us know that the ABC type or the post-germinal center type has a predominant NF-kappa B activation or dysregulation, and whereas the germinal center type predominantly has the MYC and BCL2 translocations, or perhaps the JAK-STAT or PI3 or mTOR or pathway activations. Now, we know that these are the pathways which are dysregulated, but when we actually tried to target these targets by using various therapeutic modifications or introducing novel agents over and above the standard backbone of chemotherapy, chemoimmunotherapy, that is RCHOP, we are not so successful in doing so. I just put together all the negative trials that have been that have tried to improvise upon RCHOP. But what is very important for us is to understand that these trials or these studies will actually give us a signal in a way in which the future studies have to be conducted, in a way in which the population that is being taken up for the trial has to be enriched so as to address or so as to answer the question that we actually set out looking for. So I would actually only try to take you through the initial trials where bortezomib, all of us know, is predominantly something which acts on the NF-kappa B because it's a proteasome inhibitor. So addition of bortezomib to RCHOP has not made any significant difference. Similarly, when the BCR signaling activity, which is predominantly seen in the post-germinal center type, people have tried to add ibrutinib to RCHOP. Again, we did not have a major outcome difference. And coming to robust, that is the lenalidomide, which is again used in post-germinal center, that is activated B cell type DLBCL, which did not show any difference in the PFS arms. Another important thing that we need to understand is that how actually they have taken the trial population or the patient population based on immunohistochemistry, based on gene expression profiling, or based on any other based on genomic classification. So when we look at these trials, it is important for us to understand all these variables which have been put in place. I would actually take you through the latest update of the Cavalli trial, that is a phase 2 trial where venetoclax, that is BCL2 inhibitor, a blockbuster molecule where we see here, there, and everywhere nowadays, is incorporated into R-CHOP, say for the first from day 4 to day 10. I probably am mistaken, from say day 4 to day 10. Yeah, so that is where venetoclax was incorporated into R-CHOP. And they have actually found that there is a trend, perhaps, for improved efficacy, but at the cost of severe toxicity. So if you look at the grade 3, grade 4 hematological adverse events, it is close to 86%. However, the mortality was not increased. So probably venetoclax with R-CHOP can be considered as one of the signals or one of the trials which should be taken forward in a phase 3 fashion, or a phase 3 trial, wherein we can actually have a more robust data for identifying the true benefit of adding venetoclax to R-CHOP. As of now, this is only a phase 2 trial, which gives us a pointer towards how we can incorporate this molecule in treating the high-risk population, especially with BCL2 gene rearrangement. I mean, the double-hit lymphomas, or the high-grade B-cell lymphomas with both MYC and BCL2 gene rearrangement. There has been another update of lenalidomide in the same context, that is the ERN14N trial, which also has shown a tendency or a specific PFS benefit over 3 years with the ABC type of DLBCL. But again, the confidence intervals are too broad, and they have crossed the unity. So again, as I said, that this trial, or these trials, will actually set a platform for a large scale or a more robust design with more enriched patient population, and perhaps those will answer the questions as to really can we improvise on R-CHOP by adding these targeted or therapeutic agents. As of now, adding venetoclax or lenalidomide, for that matter, for an upfront activated B-cell lymphoma, a patient with the ABC type of DLBCL, is not the standard of care. It is still only under investigations, and perhaps can be used in exceptional circumstances. Coming to entirely different, or in the same vogue of our quest for high-risk DLBCLs, is the double hit or the triple hit DLBCLs, where the WHO's 2016 classification is revised and included these in a high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement. And all of us know that MYC, BCL6 and BCL2 by immunohistochemistry, as well as by FISH, is the standard of care when we are initially evaluating the diagnostic workup of any patient with DLBCL. And there is an entity which is double expressors, where the protein expression of MYC and BCL2 and or BCL6 is measured using an immunohistochemistry. Don't take me to the cutoffs, because I'm fed up of that, and there are a lot of various variables, various cutoffs which people take across the world. So what I wanted to tell you is that if you look at the double hit lymphomas, they are predominantly of the germinal center type. So they have actually done a couple of genomic expression studies, or they have identified there is a particular double hit signature. And this double hit signature is a set of genes which are expressed in the double hit lymphomas. And surprisingly, when they analyzed the entire GCB cohort, or entire GCB DLBCL, they have identified this double hit signature in non-double hit lymphomas as well. That means, so in the entire lot of GCB, they have also identified patients who do not harbor any of these MYC or BCL2 translocations, yet harboring the DH signature. So perhaps there is something more than just the translocation of MYC and BCL2 in the germinal center type, which actually leads us to say that perhaps this entire DHL, that is double hit lymphoma, is not a homogeneous group, but in itself it is heterogeneous. When we come to the double expressor group, where we only look at, or where we look at the protein expression of MYC and BCL2, which is predominantly seen in the activated B cell type or the ABC type. So coming to the prognostication of these DHL or the double hit lymphomas, all of us know that the true double hit lymphomas hardly comprise, say, 5 to 15% or 5 to 10% of the entire DLBCL. So prognostication of a double hit lymphoma becomes even more difficult. I tried to take a single institutional data from MD Anderson, and as you can see that double hit lymphomas have a high predilection for CNS progression, and of course you can see that the stage, the IPI, and perhaps the initial treatment, all of these have an impact on the survival outcomes for double hit lymphomas. Again, I tried to take you through the gamut of studies that predominantly on the left-hand side, you can see the retrospective studies where people have tried to show what can be done beyond RCHOP. And on the left-hand side, you have certain prospective and on the right-hand side, you have certain prospective and certain large-scale studies addressing this issue as to whether or not some intensive therapy beyond RCHOP can improve the outcomes of double-hit lymphomas, because all of us agree with the consensus that double-hit lymphomas do bad with RCHOP as an upfront chemotherapeutic regimen. I would like to take you through one important study, which is a prospective dose single-arm phase 2 study, where double-hit lymphoma was subjected to dose-adjusted R-epoch regimen with intrathecal methotrexate as CNS prophylaxis, and the 2-year progression-free and event-free survival and overall survival beyond 70%. That is, similar to say a non-double hit lymphomas of the same stage or. So what we can identify here is that though it is a phase 2, a single arm study with a small number, good enough for a double hit lymphomas, perhaps dose-adjusted R-epoch can be considered, or it is appealing to consider it as one of the intensive regimens beyond RCHOP for the upfront setting or for the upfront management of double hit lymphomas. This is another retrospective analysis where people have shown that clearly when RCHOP was used as an upfront therapy for double hit lymphomas, it is inferior when you compare with other intensive regimens like dose-adjusted EPOC or hyper-CVAD or CODOX-M-IVAC. Intensive chemotherapy definitely does better when compared to RCHOP. But there is an important question which people have also addressed here, is that consolidation autotransplant in CR1, however, is not associated with any better outcomes whether you use RCHOP or with intensive chemotherapies. So probably the fact, or probably the notion that consolidating with autotransplant in CR1 in a double hit lymphoma is not really in vogue. But again, having said that, this is a retrospective analysis. There is some data to say that allotransplant in first CR consolidation, again, it's retrospective and it is an analysis from a database. So it is for us to actually go by the clinical decision that we make when we look at the patient with a double hit lymphoma in our clinics day to day. So this is again the gamut of studies which are actually going on for addressing this double hit lymphomas, targeting specific targets and trying to bring out a significant change, or trying to change the outcomes of double hit lymphomas. On the left hand side, you can see is that by default, all of us prefer to use a high intensity induction chemotherapy with CNS prophylaxis. It could be a dose-adjusted EPOC or one of the intensive regimens like hyper-CVAD. And once we achieve CR, the option of active surveillance versus considering an autologous stem cell transplant. However, this is patient-to-patient basis decision, or perhaps, and suppose if we have a partial response or progressive disease, all of us know that their median survival is less than 6 months. So enrollment in clinical trial would definitely pay a meaningful benefit here. Of course, aggressive salvage, if at all we get a chemosensitive disease by using autotransplant, is better. My last 2 slides would be on an important extranodal burden, that is CNS involvement, because CNS involvement is an important risk factor, or which segregates a particular subset of DLBCL and characterizes them or makes them to be a high risk. All of these are risk factors, and one important among them is the double hit signature itself, or the double hit lymphoma itself, and bone marrow involvement, testicular involvement, breast, uterine, kidney, adrenal involvement, and more than 2 extranodal sites. All these are considered as risk factors when we are dealing with CNS relapse. And again, in order to better delineate, or perhaps in order to identify this population of CNS high-risk patients, there is what is called as CNS IPI, which takes into account these risk factors, that is more than 1 extranodal site, elevated LDH, age more than 60, ECOG more than 1, and stage 3, 4, or kidney or adrenal gland involvement, and differentiates the patients into low, intermediate, and high risk populations. And all of us, this has been pretty good validated in 2 different cohorts. I just showed 2 cohorts here. And we advocate CNS-based prophylaxis for the patients who have a recurrence rate or relapse rate of more than 10%, so which usually fall under the high-risk CNS IPI. Now, this is how we evaluate a patient of diagnosed systemic DLBCL with CNS IPI and try to incorporate high-dose methotrexate as the CNS prophylaxis for these patients. Finally, one of the important logistic issues that we actually face when we incorporate high-dose methotrexate is incorporating or intercalating it with R-CHOP. And this is one, though it is a retrospective analysis, it's a good analysis of around 300 or odd patients from UK, where they have shown that there is no difference in survival or CNS relapse either when you intercalate the high-dose methotrexate with R-CHOP, or else you give it at the end of your treatment. But what is important is that the dose delay of R-CHOP is significantly higher when you intercalate with high-dose methotrexate, especially after day 9. So so what is important is the delivery of high-dose methotrexate, because when we were students, all of us believed that incorporation of CNS prophylaxis has to be done way early into the systemic therapy, that is, say, in the initial phases. Now, this is something which is again a pointer or a signal for us to actually formulate a better trial to actually answer this question as to intercalated high-dose methotrexate versus end of treatment high-dose methotrexate incorporation as CNS prophylaxis. Finally, to summarize, standard of care remains to be R-CHOP till date. What we need to understand, or perhaps what my dream come true, is an integration of these clinical as well as the pathological or molecular variables in order to identify this high-risk subsets of DLBCL. It's important because the outcomes with R-CHOP there seem to be inferior. But having identified what is the ideal therapy in the high-risk subset still remains unclear, though we have many pointers ahead. Dose-adjusted epoch seems to be appealing, but there is more robust data which is required. And last but not least, CNS involvement is an important and perhaps a high-risk subgroup which all of us need to remember, and it should be addressed in the beginning itself. With this, I conclude. Thank you very much, Team Varanasi, for giving me this opportunity. Thank you very much.